Good morning, all. Today, the topic for discussion is fibroosseous lesions of the jaw. So, this session includes the introduction part, classification system, individual lesions, management, and the conclusion. Fibroosseous lesions of jaw are a diverse group of conditions which is characterized by the replacement of normal bone, and the normal bone is replaced by fibrous tissue, and later amorphous bone is deposited within this fibrous tissue. Histologic features is almost similar for all the lesions. So the correct diagnosis will depend on the clinical and radiological features. Various classification systems have been proposed for this group of conditions. Mainly, two important classification systems have been discussed in this session. The first important one is the World Health Organization Classification 2005, which consists of ossifying fibroma, fibrous dysplasia, the osseous dysplasia group, which consists of periapical osseous dysplasia, focal osseous dysplasia, florid osseous dysplasia, and familial gigantiform cementoma, central giant cell granuloma, cherubism, aneurysmal bone cyst, and solitary bone cyst. The other one is the Waldron's classification 1993, which includes fibrous dysplasia. Here, the reactive lesions is again divided into non-hereditary and non-hereditary. In the non-hereditary, there comes periapical cementosseous dysplasia, focal cementosseous dysplasia, and florid cementosseous dysplasia. Hereditary one is familial gigantiform cementoma. Fibro-osseous neoplasms, cementifying fibroma, ossifying fibroma, cemento-ossifying fibroma, juvenile ossifying fibroma, and the last one is cherubism. Coming to the first lesion, periapical osseous dysplasia. As the name suggests, the lesion is occurring in the periapical area. Histopathologically, this shows cementum-like and osseous area. So earlier, it was found that there was cementum-like material, and the terminology itself was periapical cemento-osseous dysplasia. But later, it was found that there was no such cementum-like material in the histopathology. So they replaced the name cementum, and it was known as periapical osseous dysplasia. Even though the exact etiology is not known, it's thought to arise from the periodontal ligament. Clinical features, it is seen in age older than 30 years of age with a female predilection in the mandibular anteriors and usually seen associated with vital teeth. Because of that itself, it is asymptomatic and usually the lesion is noted during routine radiological examination and there is no bony expansion. Radiologically, there are three stages: an early stage with radiolucent area, an intermittent stage with mixed radiolucent radiopaque area, and an older lesion with radiopaque mass. So here you can see a well-defined radiolucent areas, which is an early stage. Of course, this is a mature stage where there is radiopacity that is attached to the periapical areas of the anteriors. Management, usually no treatment, but when we are going to excise the periapical osseous dysplasia, it tends to be removed in fragments. If associated tooth is removed, cementoma is retained within the bone. The second one is focal cementosseous dysplasia. It is detected only in routine radiographic examination. The clinical features are somewhat same to that of periapical osseous dysplasia. The age is 4th and 5th decades, female predilection, but the site is mandibular posteriors, whereas in periapical osseous dysplasia, it was mandibular anteriors. And even though the mandibular posteriors, it is edentulous posterior area, asymptomatic, and there will be swelling in older lesion causing bony expansion. Radiographic feature is similar to PCD, but the site is mandibular posterior, and you can appreciate simple bone cyst here. Management, enucleation and curettage, and the tissue appears gritty. There's no tendency to crack up. The third one is florid cementitious dysplasia. The term was suggested by Melrose. Again, it is considered to be a reactive or dysplastic change, but the appearance will be multi-quadrant. It appears in all the quadrant bilaterally and symmetrically. Clinical features: age over 30 years of age, female predilection, situs mandible more common, but it can occur in maxilla, most are symptomatic, symmetrical presentation, large lesions, there will be bony expansion, dull pain or drainage with exposure of calcified mass into the oral cavity. So there will be bilateral mixed lesion. In this panoramic view, you can appreciate the radiolucency in all the four quadrants: first quadrant, second quadrant, third and fourth. And this is almost a early stage. And in this image, IOP image, you can see it is in the later stage or mature stage. It is radiopaque or sclerotic mass. Management: symptomatic patients usually become symptomatic because of secondary infection. That is, in case of chronic osteomyelitis, and we go for antibiotic administration. Gigantiform cementoma is the hereditary part of these reactive dysplasias. It is a rare benign lesion and it has got sporadic and familial occurrence. Exact etiology is unknown. Autosomal dominant type: middle-aged to elderly with female predilection, mandible and maxillary posterior region. It is a multi-quadrant. That is, it is actually the hereditary form of florid osseous dysplasia. Painless lesion, but there will be facial deformity, tooth impaction, malalignment, and resulting in malocclusion. In this image, you can see, this is a CT image, and you can see the vast involvement of the maxilla along with the sinuses. Mixed radiolucent radiopaque areas can be seen. Management is surgical management. If there is extensive involvement of jaws, we should go for surgical management, even though it is difficult. But recurrence may occur when it is incomplete surgical removal. Next is the fibrous dysplasia, which is the most important one among this fibroosseous group of lesions. It is a non-neoplastic hamartomatous developmental lesion of bone where the same etiology, the normal bone is replaced by fibrous tissue, and the term was first coined by Lichtenstein in 1938. And there is a mutation in GNAS1 gene, and this is considered to be the etiology of fibrous dysplasia. Clinical features: age before 30 years of age, equally distributed in males and female. Two types are there: monoostotic and polyostotic. Monoostotic maxilla is a common bone. Polyostotic, again, three types: craniofacial, Lichtenstein-Jaffe type, and McCune-Albright syndrome. In Lichtenstein-Jaffe type, along with monoostotic involvement, there will be capillate pigmentations. In McCune-Albright syndrome, there will be endocrinopathies, that is precocious puberty. This is a capillate pigmentations where there is well-defined pigmentations with irregular borders, unilateral over the trunk. It can also occur over the thighs. Clinically, you can see it is poorly defined, rounded, where there will be expansion of maxilla. Sometimes it can even cause displacement of the teeth, but the intact mucosa, the overlying mucosa will be intact. And in the X-ray, you can see an orange peel or thumbprint appearance, pudy orange appearance, and you can see the boundary of the lesion is merging well with the normal bone. Radiographic features: three patterns. The first one is radiolucency, which can either be unilocular, then a mixed stage, and finally it is a ground glass pudy orange appearance, and finally a increased radiopaque stage, that is a mottled appearance. So here you can see this ground glass appearance over the mandibular area, and also you can see the expansion here. But in case of two ossifying fibroma, which is a tumor considered lesion, it is more ill-defined borders fibrous dysplasia have. And histopathologically, we can see the immature woven bone in C or Y Chinese pattern, Chinese character appearance. Management, the enlargement is slow, so persists until cessation of the skeletal growth. The treatment of choice is surgery. Small lesions you can excise in toto, larger lesions, correction of aesthetic and functional disturbances. Because it is vascular, there will be bleeding problems during surgical interventions. Next is cherubism. It is a familial counterpart of this fibrous dysplasia, autosomal dominant type, and the etiology is considered to be trauma. Small children between 5 to 10 years, no sex predilection. It can be seen bilaterally in the common situs mandibular angle. Also, it can occur in maxilla. But when both mandible and maxilla is involved, it gives a child a typical cherubic appearance. And when the maxilla is involved, the skin becomes taut, giving an eye raised to heaven appearance. All the functional activities are involved: speech, mastication, deglutition, limited jaw movement. Classification by on-call: grade 1, grade 2, and grade 3. Grade 1 starting with ramus, grade 2 ramus body and maxillary tuberosity, grade 3 entire maxilla and mandible, and there will be typical facial deformities. Radiologically, we can see multilocular radiolucency, teeth hanging in air expansion, and expansion of the buccal and lingual cortical plate. The inferior alveolar canal is displaced when involved in the mandibular arch and encroachment into maxillary sinus in the maxillary arch. Teeth hanging in air appearance is an important radiological appearance of cherubism. Histologically, we can see perivascular eosinophilic cuffing. Management is it will spontaneously regress before 20 years of age, otherwise go for cosmetic recontour. The cementosifying fibroma, also known as ossifying or cementifying or as cementosifying fibroma, 3rd to 4 decades, female predilection, the mandibular posterior region, common site. It is a well circumscribed expansile growth with a centrifugal growth pattern. Radiographic features: it is a well-defined radiolucency with central calcification, and a radiolucent rim can be seen along with sclerotic border. Management is enucleation. Juvenile ossifying fibroma: it is the same ossifying fibroma affecting children of 15 years or younger, usually seen in extraanatomic bone. Child or adolescent, no sex predilection. Most common is extraanatomic bone, but when in jaws, maxilla, resulting in parietal swelling, facial swelling, and expansion is common. Microscopic features: it has got two appearances, trabecular and psammomatoid, with osteoid in fibrous stroma. Osteoid tissue can be appreciated among the fibrous stroma. Management is larger lesion, thorough enucleation, but recurrence is more common in the adult type of ossifying fibroma compared to that of juvenile type. Paget's disease: it was first described by Sir James Paget, and the disease was known as orchitis deformans. It is a non-inflammatory condition where there is both osteoclastic and osteoblastic repair. Paramyxovirus is also considered to be one of the etiology of this Paget's disease. Ages: older people, men is affected more than female population. Usually long bones and skull is affected. Symmetric presentation, asymptomatic at early stages and later painful. Because of the line-like facial deformities, it is known as leontiasis ossei. The dentures become tight and there will be increased head size along with pulp calcifications, hypercementosis, and aggregates. There will be increased lab values like serum alkaline phosphatase, increased hydroxyproline, and increased serum calcium and phosphorus level. Radiographically, 3 stages: radiolytic, a mixed stage, and then radiopaque stage. Here you can see the cotton wool appearance in this skull view. Here also, cotton wool appearance. And in the histopathological feature, there will be jigsaw puzzle or mosaic pattern of reverse line. Management, main indication is pain, cardiac failure, and hypercalcemia. So we have to treat with calcitonin, diphosphonates, and nitramycin. Calcitonin suppress bone resorption, diphosphonate inhibit the resorption, and nitramycin is cytotoxic. For dental surgeons, there will be difficulty in endodontic procedures, extraction, hemostasis, secondary infection, antibiotic prophylaxis have to be given, and the main one complication is malignant potential. Aneurysmal bone cyst, it is a ballooned out radiological appearance where trauma or fracture is considered to be the etiology. First 3 decades of life, female predilection, mandibular posterior region, giving a hydraulic appearance. And histopathologically, we can see multinucleated giant cells, fibroblasts, and blood-filled spaces. The typical radiological appearance is multilocular, that is honeycomb or soap bubble appearance. Also, it has got 3 phases as all other fibrosseous lesions. Management is when surgically open, care should be given because blood pools up. High recurrence rate can be seen, so thorough curettage should be done. Next is central giant cell granuloma. It is believed to be a reactive lesion caused by a trauma. Seen in younger people less than 20 years of age with a female predilection. Mandible is a common and the site is very important. It is seen anterior to the first molar. 2 types, aggressive and non-aggressive. Aggressive as the name suggests itself, it has got rapid growth, swelling, recurrence. Non-aggressive, asymptomatic, slow growth, and seldom recur. It has got 3 stages. There will be a cyst-like radiolucent stage, a multilocular appearance with residual septae, and finally the resorption of the septae giving to a sclerotic mass or the mature stage. Aggressive type, there will be resorption of the bone or resorption of the root, and there will be perforation of the cortex. Non-aggressive type, there will be non-root resorption or nor the cortex will be normal. Histopathologically, there will be fibroblast, multinucleated giant cells with new trabeculae of osteoid bone at the periphery. Management is for non-aggressive type, simple curettage. For aggressive lesion, you have to go for curettage plus peripheral osteotomy along with corticosteroids and calcitonin. The last lesion of the session is solitary bone cyst, which is also called as traumatic or hemorrhagic bone cyst. The theory most widely accepted is trauma hemorrhage theory. The clinical feature is seen in 10 to 20 years of age with a male predilection. The site is mandibular, premolar, molar areas. It's a common site. It doesn't mean that it should occur only in the mandible. It can be seen in other areas also, but the most common area is mandibular posterior region. Bilateral presentation common, asymptomatic, and the teeth is vital. Radiologically, you can see well delineated radiolucent defect. It is well delineated. You can see the edges or you can trace the edges here. And there is dome-like projections that is scalloping upwards in between the root. Rarely only it appears as multilocular lesion. Management is curettage. Recurrence is less common and because of that it has got an excellent prognosis. So to conclude, the designation or the term fibro-osseous lesion is not a specific diagnosis. You should know there are various diseases that comes under fibro-osseous lesions. So you should be able to differentiate those lesions because the treatment plan for each lesion is different. Specific diagnosis is critical because the treatment varies from none to surgical recontouring to complete removal. So that's all for today. I hope you have a good understanding of this group of lesions. Thank you so much.